My name is Mark Banaka. I'm one of the associate editors at JACC, and I'm honored to have the opportunity to interview Dr. Christy Ballantyne, who is the lead author on a really exciting publication that will be simultaneously published at the American College of Cardiology with a presentation looking at the effect of targeting ApoC3 with Plozasiran on the lipoprotein particle size and number in patients with hypertriglyceridemia. So welcome, Dr. Ballantyne. I don't know if you want to introduce yourself.
Thanks, Mark. I'm Christy Ballantyne. I'm Chief of Cardiology and Cardiovascular Research, Baylor College of Medicine, a long-standing interest in preventive cardiology and lipids and atherosclerosis.
Well, welcome. And I'd love to tell the listeners a little bit more about your paper, and maybe you could just briefly summarize some of the key findings, and I have some questions for you.
Yeah, so, the challenge we've had is that statins are great drugs, but we know we have these patients who still have high triglycerides. And if they're really high, very high triglycerides, there's a risk for pancreatitis, also for heart disease. And then you have that 2 to 500 zone where, mixed hyperlipidemias. And it's been disappointing because when we added, 5 weeks to statin, we didn't reduce events. And also, for whatever reason, ApoB went up. And non-HDL cholesterol went out. So Plozasiran is targeting ApoC3. It's an siRNA. And the target came from genetic studies, first with the Amish, that people with, basically loss of function variants in ApoC3, less postprandial lipemia, lower triglycerides, better lipid profile, less coronary calcium, and also some benefit in terms of these big, huge studies with many cohorts of ASCVD. So this looked at 2 studies, Shasta, very high triglycerides over 500, and Muir, 2 to 500, and it looked at the LDL particles and the triglyceride-rich lipoprotein particles. And so, as expected, the triglyceride-rich lipoprotein particles showed a big reduction. What was reassuring is that overall LDLP did not go up. Small, dense LDL particles went down quite a bit. There was some increase in the larger LDL particles, and then HDL particles, large HDL particles, went up. So these are favorable changes that we would expect to see. Overall, non-HDL cholesterol went down substantially, and ApoB went down some with it. But it highlights to this key is, there's some data out of UK Biobank that these triglyceride-rich particles may be more atherogenic per particle than LDL particles. Now, LDL particles are more common. They're much more abundant, so we don't want to raise LDL particles. But if you can reduce triglyceride-rich lipoprotein particles and reduce small dense LDL particles favorably, hopefully, we have to test this. That's the other thing, is you might have a beneficial effect, which we have yet to see with fibrates on top of statins in patients with mixed dyslipidemia.
Thank you. Excellent summary. And, I want to dig into this LDL piece of this, which I think is so fascinating because, for some it's sort of, LDL is bad and lower is better. But talk to me a little bit more about, and the listeners here, around particle size. And, not all LDL is the same, right, in terms of atherogenicity.
So it turns out there's a range of particle size. We've always talked about LDL as if it's one thing, but there's different ways of characterizing LDLs. One of them is by ultracentrifugation. This is NMR spectroscopy, and you have smaller and larger LDL particles. Smaller particles are thought to be able to infiltrate into the arterial wall more easily. It also turns out that these smaller particles have some other properties. They're actually somewhat triglyceride enriched, and some of them looked at these kind of electronegative. There's this whole link between, lipoproteins, triglycerides, and inflammation. But what we don't, overall, probably the most important thing, what is the total LDL particle concentration? But we've never been able to have a therapy that really selectively lowered, the small dense LDL particles without having some other adverse effects. So it's going to be interesting to try to tease this out. The other thing that kind of came up is there were some waterfall plots, but triglyceride-rich lipoproteins go down very consistently in everyone. There is a little bit more heterogeneous response in terms of changes in the LDL particles. And I think that's going to need some, this is phase 2 study. In the phase 3 study, we'll need to look at that a little bit more. But it's interesting as to why is there, this each person is different. What is the variability of that, and why would there be some people having more robust changes in total particles? We also looked at LDL triglyceride went down too. That's another bad marker for a bad particle. We always talk about LDL cholesterol, but LDL triglyceride is also thought to be an important atherogenic marker.
Yeah, so the concept, I guess, that, and correct me if I'm wrong here, that even if with a fixed LDL number, that you could shift the particle type within the LDL to one that's more or less atherogenic. Is that correct?
So I think that is correct. Now, what ends up happening is we'll probably see. I think these drugs may be best with the statin background because these small length LDL particles don't get taken up quite as well by the LDL receptor.
Right.
If you convert them to larger particles, it'd be good to have a statin on board because then you'll clear those particles out. So I do think this will probably be best in combination with a statin or PCSK9 or something that's increasing the other receptors, so that as you're able to convert those small particles to bigger particles, that you're also clearing them out.
And did you measure reverse cholesterol transport, or are there ways to do that?
We did not, and that's very complicated to measure with it. But the real test is going to be, which hopefully, keep our fingers crossed, will be started somewhat soon. Will be a large outcomes trial.
Yes.
And one of the things in terms of the outcome trial will be is which patients go into the study and how high should the triglycerides be. We'll hopefully be hearing more about this in the fairly near future, but I think it's really exciting for us to test again. We don't have anything. We had one thing that worked, which was EPA, icosapentaenoic acid, didn't appear to be a lipid effect. And there's some controversies as to what was the effect with it. So it's really going to be interesting to look at a genetically validated target and see what we come up with.
Well, very, very exciting. Well, thank you for talking about your paper today. Congratulations again. We're looking forward to the presentation at ACC and the simultaneous paper. And as you said, future work in an outcome study, hopefully to tell us whether this is a new tool for our patients with risk. Any other comments, Dr. Ballantyne, before we close?
No, I think it's exciting. This is the data on an siRNA. There's also an antisense oligonucleotide that targets ApoC3. So hopefully, as these programs march along, we'll get a lot more data. We'll have a CTA data in the not too distant future from the other program too. But we're really interested in terms of how do these changes in lipoproteins translate to changes in atherosclerosis and events, and that's the ultimate story. But we're excited about what we saw thus far.
Well, great. Thank you again, and congratulations on your work.
Okay, thanks, Mark.